maybe talk a bit about your experience, on the trial with the toxicity profile around Camizestrant. What we read certainly seems like it's a very, very tolerable drug.
Right.
But we hear about things like bradycardia and things like that. So maybe share your experience. I know on the trial, the toxicity was very low grade overall.
Right.
And so that was reassuring, but curious what you saw.
Yeah. So maybe all the way back to what you mentioned earlier, how was it to explain it to a patient?
Right. Exactly.
So I think at the time we didn't know maybe as much about Camizestrant, but it was reassuring, at least in the preclinical data and the clinical data that we did have, that it was encouraging to be able to say to them, if we do switch you to this drug, the likelihood is that you're going to do very well. And then the more experience we had, it confirmed and reaffirmed that. The study showed this as well. Overwhelmingly, great tolerance. Nausea was very low grade 1, like we've seen in other trials with oral SERDs. Bradycardia is a drug effect that we can see with other SERDs as well. But the encouraging thing there is that although we were monitoring with EKGs, it was really just minor point drop, and it was asymptomatic. Patients did not feel that effect. We only recorded it, which was great to see. And then the eye effects are not a structural issue. And I think that was incredibly important for the patients to understand. It wasn't, a thing that we could capture on an eye exam. It was flashes of light, particularly with changes in dimming of light. So when you went from a dark room to a bright room, or you were, driving at night, it could be, flashes of light in your periphery, but it didn't affect the actual functioning of their everyday life.
Right. And I think that's really important to point out, because whenever we read, something about your vision, that's something for patients. It's so important for their independence and, their ability to be able to live, to drive, to be mobile, all of those things. I think sometimes when we first hear about ocular toxicity, sometimes for patients, it's really scary.
Absolutely.
So I think to have you kind of explain how patients experience that, and so that we can, as clinicians, relay that to them, that, we're not going to see damage in your vision or structural change in the eye itself or the cornea or, any of those things, but that we might see some of these changes, which I'm not sure if you talk to patients about some minor lifestyle modification in terms of changing from dim to, or you just felt like patients didn't even need that.
No, because I think the frequency of when it happened and how often it happened, it was in the order of 1 to 2 times a week.
Oh, that's
so it wasn't even something that they saw every single day, every time they turn on and off a light. It wasn't to that degree.
Yeah. Oh, that's so reassuring.
That is why ultimately it felt like less of a concern and much more reassuring for all of us.
Absolutely. I'm so glad to hear that. And I was reassured to see that although the bradycardia you mentioned, which can be a class effect and was largely asymptomatic in the trial, but it wasn't even associated with QT prolongation.
Right.
Sometimes we're really concerned about these patients, and many of them are on lots of other medications. For example, antiemetics and cardiac meds for blood pressure, different things which inherently cause QT prolongation. So that always creates a bit of a challenge for us as clinicians when we go to prescribe a therapy and the dreaded pop-up on the electronic medical record saying interaction, right, could cause QT prolongation. So I was happy to see that although bradycardia was largely asymptomatic and it didn't translate to QT prolongation. So I thought that was really important.